Have you ever found yourself needing to get up to speed on a really complex topic? Maybe, for a big meeting, or just because your curiosity couldn't be contained. You need the crucial insights, right? The surprising facts, without getting completely bogged down in every single detail.
Absolutely.
Well, if that sounds familiar, then you are absolutely in the right place. Welcome to the Deep Dive.
Glad to be here.
Imagine you're a doctor, maybe in the ER, faced with a patient who has these kind of vague symptoms. A persistent fever, perhaps? Unexplained fatigue? Maybe some joint pain?
Yeah, not always obvious.
Nothing immediately screams heart infection. Traditionally, diagnosing something like infective endocarditis, well, it could be a long, challenging road, often a race against time.
It really could.
Today, we're diving into how that race is getting, faster and hopefully more precise. We're cutting through the complexity of medical diagnostic criteria.
Specifically,
we're unpacking the newly updated 2023 Duke ISCVID infective endocarditis, or IE, criteria.
the new guidelines. Big updates there.
Exactly. Our mission is to highlight what's truly important in these significant updates, show you how these new guidelines are fundamentally changing how doctors diagnose this serious heart infection.
Think of it as your shortcut.
Precisely. Your shortcut to understanding the cutting edge of IE diagnosis. And just so you know, our insights come directly from the official 2023 Duke ISCVID IE criteria.pdf itself.
Right, the source document, including all the tables and the proposed changes.
So just take a second to consider how critical precise diagnostic tools are in medicine, especially for conditions like IE where, getting it right early on can make all the difference.
Yeah, absolutely vital.
Okay, so let's unpack this. First off, at its core, what exactly is infective endocarditis, for anyone needing a quick refresher?
Yeah, simply put, infective endocarditis, or IE, is an infection of the heart's inner lining. Most commonly, it affects the heart valves.
And it can be dangerous.
Oh, very. It can quickly become life-threatening. So getting the diagnosis right and getting it fast is absolutely critical. That's why its diagnosis relies on a very specific set of criteria.
And these updated Duke ISCVID criteria, they're meant to streamline that process, right? How are they categorizing the diagnosis now?
That's right. The updated criteria categorize IE diagnosis into three main classifications: definite endocarditis, possible endocarditis, and rejected endocarditis.
Okay, 3 buckets.
Exactly. And the goal is really to provide clearer pathways to each one.
So definite endocarditis, that's the one you really want to nail, the absolute confirmation. How is that established under these new guidelines?
Right. A definite diagnosis is established in one of 2 primary ways, either through pathologic criteria or clinical criteria.
Pathologic, meaning direct evidence from tissue.
Precisely. Pathologic criteria are quite direct. If microorganisms, bacteria or fungi or active endocarditis are directly identified in specific heart tissues.
Like what kind of tissues?
Like vegetations, which are essentially these clumps of bacteria and blood cells forming on the heart valves, or maybe within an explanted prosthetic heart valve, or even in an arterial embolus, a clot that's traveled.
So, physical proof.
Exactly. That's a definite diagnosis. It's direct, undeniable evidence.
Okay. And then there are the clinical criteria. You said this is where we see some of the most significant changes.
Yes, this is where it gets really interesting from a practical standpoint. Under the new guidelines, a definite clinical diagnosis now requires either 2 major criteria.
Okay, 2 major ones.
Or 1 major criterion and 3 minor criteria.
1 major, 3 minor.
Or, and this is the new part, a completely new pathway. 5 minor criteria.
Whoa, hang on. 5 minor criteria can now equal a definite diagnosis. That sounds like a huge shift.
It is. It's a really significant change.
Can you maybe walk us through a scenario where this new pathway might genuinely make a difference for a patient? Like, how would that play out?
Yeah, absolutely. Think of a patient, maybe they come in with confusing, nonspecific symptoms. Perhaps they have a fever, that's 1 minor. Some unusual skin lesions, maybe Janeway lesions, that's another. And maybe some unexplained kidney trouble fitting the glomerulonephritis definition. That's 3 minor criteria.
Okay, so 3 clues, but nothing definitive yet.
Right. In the past, if a classic major criterion like, say, a large vegetation seen clearly on an echocardiogram wasn't immediately obvious, that patient might have been stuck in the possible category.
Delaying treatment.
Potentially delaying definitive treatment, yes. Now, with more pathways, especially this 5 minor criteria option, maybe they also have a predisposing factor like a prior valve repair, that's 4, and maybe a positive blood culture that doesn't quite meet major criteria, that's 5.
Ah, so those subtle clues can add up now.
Exactly. They can combine to push them over the threshold to a definite diagnosis much sooner. It allows for a more inclusive diagnosis, especially for those cases with an atypical presentation, and that can be absolutely life-saving.
Right, it's about connecting more dots, even when the obvious smoking gun isn't there right away. Makes sense. And what about possible and rejected endocarditis? How are they defined?
Possible endocarditis is now defined by either 1 major and 1 minor criterion or 3 minor criteria, so kind of the intermediate zone.
Okay.
And rejected endocarditis is when an alternate diagnosis firmly explains the symptoms. Or maybe the patient recovered despite very short antibiotic therapy, like less than 4 days, which would be unusual for true IE.
Or nothing's found later.
Exactly. Or if there was no evidence of IE found at surgery or autopsy after that short antibiotic course. Essentially, it's when the evidence points strongly away from IE or just doesn't meet the criteria for possible.
That whole structural shift, it feels much more logical, more flexible. But okay, to really understand how doctors get to definite, we need to dig into the building blocks, those major criteria.
Right.
Let's start with the microbiologic evidence. You mentioned big updates here, integrating some cutting-edge stuff. What are the revolutionary changes clinicians really need to know?
Yeah, this is where we see significant modernization. I mean, positive blood cultures are still absolutely central, of course. But the new criteria have actually removed the old strict requirements for specific timing and separate venipunctures for those cultures.
Oh, really? Why the change?
It's a practical change, really.
Yeah.
It recognizes that in urgent situations, getting blood cultures quickly is paramount. Clinicians shouldn't be, penalized diagnostically for not adhering to rigid collection protocols if the overall clinical picture is strongly suggestive of IE.
That seems like a sensible, real-world adjustment. Okay, what about the types of bugs, the organisms themselves? Has the list of typical IE culprits expanded?
It has, quite significantly. The definition of typical organisms associated with IE has broadened. We're now including a wider range of bacteria that we now understand are frequently implicated.
Such as?
Key additions include Staphylococcus legionensis, that's a specific type of Staph enterococcus faecalis, most streptococcal species actually, except for the ones causing typical pneumonia or strep throat.
So more strep species count now.
Yes, and also includes things like Granulicella and Abioturfia species, sometimes called nutritionally variant streptococci, and Gemella species, too.
Okay, a wider net. And I remember reading it gets even more specific for patients with intracardiac prosthetic material, things like artificial valves or pacemaker wires.
Exactly right. For patients with implanted devices, the list of typical pathogens expands even further.
Why is that? Are those devices more susceptible to different bugs?
They can be, yes. Infections involving foreign material often involve bacteria that might not typically cause native valve endocarditis. So for these patients, the list now includes several types of coagulase-negative Staphylococci, which are common skin bacteria.
Okay.
Also, Corynebacterium species, specifically C. striatum and C. jichium, things like Serratia marcescens, Pseudomonas aeruginosa, Cutibacterium acnes, formerly known as Propionibacterium acnes.
Wow, quite a list.
And even non-tuberculous Mycobacteria and Candida species, which are yeasts. It really broadens the net for diagnosing infections around these implanted devices, which can be notoriously tricky to pin down.
That makes sense, covering more bases for those complex cases.
Right.
So a much more comprehensive net. But what about those really hard-to-grow organisms, ones that are super tricky to identify in the lab? Any new major criteria for them?
Crucially, yes. This is another major step forward. New major criteria have been added specifically for organisms known as fastidious pathogens.
Fastidious meaning finicky, hard to grow.
Exactly. They're notoriously difficult to cultivate using standard lab techniques. So the criteria now include positive PCR polymerase chain reaction or other advanced nucleic acid-based techniques.
Like sequencing.
Yes, like amplicon or metagenomic sequencing. If these tests are positive for specific organisms like Coxiella burnetii, which causes Q fever,
Right.
or Bartonella species, which can cause cat scratch disease, among other things, or Tropharema whippleyi, the cause of Whipple's disease. If you find their DNA in the blood, that can now count as a major criterion.
So we're basically integrating cutting-edge molecular diagnostics directly into the core criteria. How big a deal is that shift? especially for cases where traditional cultures might have come back negative.
Oh, it's a true game changer, honestly. Think about those cases where you strongly suspected IE, but the blood cultures were stubbornly negative because the bug just wouldn't grow.
Leaving doctors without clear answers.
Exactly. Growing these fastidious pathogens in a lab used to take weeks. Sometimes it just never happened at all. Now, with advanced PCR or sequencing, we can potentially identify the specific culprit in, days.
That speed must be critical.
For a rapidly progressing infection like IE, that speed is absolutely vital. It means starting the right targeted antibiotic treatment much sooner, potentially saving lives or preventing serious complications that might have resulted from undiagnosed or mistreated infections.
And it's not just PCR, right? You mentioned antibodies.
Correct. Specific antibody titers are also now recognized as major criteria for Coxiella burnetii specifically, and antiphase IgG antibody titer over 1.800, and for Bartonella species, looking at both IgM and IgG titers with IgG over 1.800.
So different ways to detect these tricky bugs.
Exactly. It reflects a much more complete modern understanding of how to detect these elusive infections using the best tools we now have available.
Okay, that truly modernizes the diagnostic approach on the micro side. Let's shift gears to the imaging major criteria. We're seeing a broader view of the heart here too, right?
Yeah.
Echocardiography, the heart ultrasound, obviously remains key.
Absolutely. Echo is still the cornerstone. You're looking for those classic signs. Vegetations, those clumps we talked about, or other structural damage like valvular or leaflet perforation, maybe an aneurysm on the valve, an abscess, which is a collection of pus near the valve.
Or problems with artificial valves.
Yes, or a pseudoaneurysm, which is like a contained rupture near the valve, an intracardiac fistula, which is an abnormal connection, or evidence of new significant valve leakage regurgitation or a new partial dehiscence, meaning the artificial valve is starting to come loose. All classic echo findings.
But the big news, as I understand it, is the integration of other advanced imaging. Cardiac CT.
Yes. Cardiac computed tomography, or CT findings, are now formally added as a new major criterion. They are considered essentially equivalent to echocardiography for diagnostic purposes in this context.
So if a high-quality cardiac CT clearly shows signs of IE, like an abscess or a pseudoaneurysm, that scan finding alone can count as a major criterion.
That's the idea, yes. It acknowledges that CT can sometimes visualize certain complications, particularly those around the valve structures, perivalvular, even better than echo in some situations.
Interesting. And then there's another really big one, 18-FFDG PT-CT imaging. This is that scan using radioactive sugar, right?
Correct. 18-FFDG PT-CT uses a tracer, fluorodeoxyglucose, which is basically a sugar molecule tagged with a radioactive isotope. Areas of high metabolic activity, like inflammation or infection, take up more of the sugar and light up on the scan.
And now this is a major criterion for IE.
It is, yes. Abnormal metabolic activity detected by 18-FFDG PT-CT around the heart valves or implanted material is now a new major criterion.
Where specifically does this apply?
It applies to suspected infection involving native or prosthetic valves, ascending aortic grafts if the valve is also involved, intracardiac device leads like pacemaker wires, or other prosthetic material within the heart.
Is it particularly useful for prosthetic material?
It's considered especially helpful there, yes, because sometimes echo can be limited by shadowing or artifacts from the artificial material. BTCT can often detect inflammation around these devices quite well.
But there's a catch, right? Something about timing.
Yes, a very important nuance. For this finding to count as a major criterion involving prosthetic material, the PT-CT scan needs to be performed at least 3 months after the surgical implantation of that material.
Why the 3-month cutoff?
Because there can be some normal postoperative inflammation and healing processes during those first few months that can also cause increased FDG uptake. So scanning too early might lead to a false positive result for infection.
Ah, okay. So waiting 3 months helps distinguish true infection from normal post-surgical changes. Makes sense.
Precisely. It's an important distinction to prevent misdiagnosis based on expected healing.
Right. Okay, finally, under the major criteria, there's one more category. Surgical, and another significant addition here.
Yes, indeed. Evidence of IE that is documented by direct inspection during heart surgery is now itself a new major criterion.
So the surgeon literally sees the infection.
Exactly. Think of it as the surgeon being in the operating room, looking directly at the heart valve and seeing clear signs of endocarditis like vegetations or abscesses that maybe weren't fully clear on pre-op imaging.
And that visual confirmation now counts as major.
Yes. It provides direct, undeniable evidence. Even if other imaging or microbiology tests weren't completely conclusive before the surgery started.
Does that mean they don't need to send samples anymore?
No, absolutely not. The source document is very clear on this. It explicitly states this criterion shouldn't be interpreted as giving license not to send appropriate samples, valve tissue, vegetations for microbiology, and pathology studies. Those are still crucial.
Okay.
It just means that the direct intraoperative observation itself is now recognized as a very strong piece of diagnostic evidence, meeting the threshold for a major criterion.
Got it. So we've covered the heavyweights, the major criteria, the things that often really point strongly towards IE. But just as crucial, sometimes even more so in complex cases, are the more subtle indicators, the minor criteria. These are the supporting pieces of evidence. And you mentioned earlier, 5 of these can now add up to a definite diagnosis.
That's right. They play a really critical role, especially in combination.
And these have also seen some really smart updates too, reflecting a more nuanced understanding of IE.
Definitely. The minor criteria have been refined and expanded in several key areas.
Okay, let's start with predisposition. What puts someone at higher risk? Has that list changed?
Yes, the list of predisposing factors has been updated. It still includes the familiar risks like having had IE before, having a prosthetic heart valve or prior valve repair, certain types of congenital heart disease, moderate or severe valve problems like regurgitation or stenosis.
Okay, the known risks.
Having an endovascular CIE, that's a pacemaker or defibrillator with leads in the heart, hypertrophic obstructive cardiomyopathy, and injection drug use, those are still there.
What's new?
Newly added predisposing factors are transcatheter valve implantation or repair, think TAVR or MitraClip, these minimally invasive procedures, and also explicitly listing any prior diagnosis of IE as a risk factor in itself.
So acknowledging newer procedures and reinforcing that past IE is a major risk. What about fever?
Fever, thankfully, remains unchanged. Still straightforward. A documented temperature greater than 38.0 degrees Celsius, which is 100.4 Fahrenheit.
Simple enough.
Okay,
moving to vascular phenomena. These are clues from the body circulation, right? Like emboli.
Exactly. These are signs that infected material might be breaking off from the heart and traveling through the bloodstream. The list here has been significantly expanded and clarified.
Well, what's included now?
It includes clinical or radiological evidence of arterial emboli clots going to major arteries, potentially causing stroke or blocking blood flow to limbs, septic pulmonary infarcts, which are areas of lung damage from infected clots going to the lungs.
Okay.
Mycotic aneurysm, which is a weakening and bulging of an artery wall due to infection, intracranial hemorrhage, or bleeding in the brain. Conjunctival hemorrhages, which are tiny bleeds in the whites of the eyes. Janeway lesions, which are painless spots on palms or soles. And purulent purpura, which is like infected bruising.
That's quite a range of signs. Any key additions?
Yes, crucially, splenic abscesses, collections of pus in the spleen, and cerebral abscesses, collections of pus in the brain, have been specifically added to this list of vascular phenomena.
Recognizing that infection spreading to form abscesses fits this pattern.
Correct. Their inclusion helps capture these more complex systemic presentations of IE under this category.
Got it. Next up, immunologic phenomena. These are clues from the body's immune reaction to the infection.
Yes, signs that the immune system is reacting to the chronic infection. This category still includes things like a positive rheumatoid factor test, Osler's nodes, which are painful nodules on fingers or toes, and Roth spots, which are hemorrhages seen in the retina of the eye.
Okay, the classics. Anything clarified or added here?
Yes, they've significantly clarified the definition for immune complex-mediated glomerulonephritis.
That sounds complicated. Kidney damage from the immune system.
Essentially, yes. It refers to kidney damage caused by the body's immune response to the infection, where immune complexes get deposited in the kidneys. The new criteria give it a very clear definition now. It involves having unexplained acute or worsening chronic kidney injury, plus at least 2 specific findings like blood or protein in the urine, certain cellular casts in the urine, or specific blood markers like low complement levels or cryoglobulins, or having a renal biopsy, a kidney tissue sample that is clearly consistent with this type of immune complex-mediated kidney disease.
So much more objective criteria for counting kidney problems as an immunologic sign.
Exactly. This clarity makes it much easier for clinicians to definitively classify kidney issues related to IE as a minor criterion when appropriate.
That seems really helpful. Okay, then there's a category for microbiologic evidence falling short of a major criterion. What fits in here now?
This category covers situations where you have some microbiological evidence pointing towards IE, but it doesn't quite meet the stricter requirements for major criterion.
Like what?
Well, it now explicitly includes a positive PCR or other nucleic acid-based test for an organism that could cause IE found in a sample from a normally sterile body site, like joint fluid or pleural fluid, provided it's not cardiac tissue, prosthesis, or an embolus, as those would trigger other criteria.
Okay, finding the bug's DNA somewhere unexpected.
Right. And also, importantly, a single finding of a common skin bacterium identified by PCR on a sample from a heart valve or pacemaker wire without any other clinical or microbiological supporting evidence that now specifically qualifies as a minor criterion.
Ah, so even a subtle genetic clue from a potential contaminant isn't just dismissed outright.
Exactly. It acknowledges that sometimes, especially when combined with other minor criteria, even that subtle clue could be significant. It avoids throwing out potentially valuable information too early.
That feels like a more inclusive approach.
Good.
And even imaging can be a minor criterion sometimes.
It can, yes. Remember we talked about the 18 FFDG PTCT scan?
The 3-month rule for prosthetic material for it to be major.
Right. Well, if you see abnormal metabolic activity detected by that PTCT scan within those first 3 months of implantation of prosthetic material, that now counts as a minor criterion.
Ah, so it still counts for something, just not as strongly.
Precisely. It distinguishes it from the major criterion you get for PTCT findings later on, after that initial post-op period. It reflects the slightly lower certainty of infection during that early window.
That 3-month distinction is really key then for interpreting PTCT.
Okay, one last one. Physical examination criteria. What's the update here?
There's a specific update regarding heart murmurs. Finding new valvular regurgitation, meaning a new leaky heart valve that's identified just by listening with a stethoscope, by auscultation.
A new murmur.
Yes, a new murmur suggesting a leaky valve. That can now be counted as a minor criterion, but only if echocardiography is not available.
Oh, interesting. So it's like a backup criterion.
Kind of. It's a pragmatic recognition that in some resource-limited settings, a skilled physical exam, including auscultation, might be the first or even the only clue available initially. But not just any change in murmur.
No, the guidelines are very clear. Simply a worsening or a change in the character of a pre-existing murmur is not sufficient to meet this minor criterion. It really has to be evidence of a new leak identified on exam and only used if you can't get an echo to confirm.
Phew. Okay. That is a lot of detail to digest, covering everything from, molecular tests to listening with a stethoscope. It really shows how intricate these diagnostic puzzles can be.
It does, and how the criteria try to incorporate all these different types of evidence.
So we've really covered a lot of ground here digging into these 2023 Duke ISCVID, IE criteria. Stepping back, what does this all mean for you, our listener, and maybe for the broader landscape of medical diagnosis?
Well, I think these updates really represent a significant modernization of how we diagnose IE. They're thoughtfully integrating advanced molecular technologies like PCR and sequencing and sophisticated imaging like cardiac CT and PTCT directly into standard practice.
Moving beyond just blood cultures and basic echo, in a way.
Exactly. And if we connect this to the bigger picture, I think these changes really highlight how rapidly medical understanding and our diagnostic tools are evolving. We're constantly refining our ability to identify and hopefully combat complex diseases like IE more effectively.
And the ultimate aim is clear, right? It's about improving diagnostic accuracy.
Absolutely. The expanded criteria, the new pathways like the 5 minor criteria rule, they should hopefully lead to earlier and more appropriate targeted treatment for patients. And that is absolutely critical for a serious, potentially deadly condition like infective endocarditis.
It also feels like they reflect a much more comprehensive understanding of all the different ways IE can present itself.
I agree. Including those more subtle signs or infections caused by less common pathogens or infections involving prosthetic devices, things that might have been missed or very difficult to definitively diagnose under the older rules.
We have truly taken a deep dive today, haven't we? Really getting into the weeds of the 2023 Duke ISCVID EA criteria, uncovering how these diagnostic pathways are being, revolutionized by new insights into microbiology, imaging, and clinical presentation.
It's a fascinating example of how medicine adapts and incorporates new knowledge and technology.
Definitely. So here's a final thought for you to maybe mull over as you go about your day.
Okay.
Consider how this ongoing integration of cutting-edge technologies, things like advanced genetic sequencing, sophisticated imaging into diagnostic criteria doesn't just make diagnoses more precise. Does it also fundamentally change our definition of what it even means to be well-informed in medicine today?
That's a deep question. Keeping up is certainly a challenge.
It is, and it makes you wonder, what other areas of healthcare do you think are on the brink of similar transformational updates, driven by this wave of new technology and our evolving understanding of disease? Something to think about.